Hello, everybody, and welcome to the Downsized. My name is Christopher Durham.
I'm Laraine Durham.
And today is another of our continuing series talking to medical professionals about this whole great big world of GLP-1s. If you're new here, we're the Downsized. We're the channel that talks about all things GLP-1, health, wellness, and all things in the news, tell personal stories, talk to doctors, pharmacists, PAs, you name it, pretty much every day. So if you haven't already, please take a moment to like and subscribe.
Yep.
As always, we have to give the medical caveat. What's the medical caveat?
We're not doctors. This is not medical advice. This is just for entertainment and educational purposes only. Please consult with your doctor or weight loss professional before starting any health or fitness journey.
And while Joe is a medical professional, he's not your medical professional. So this isn't advice for you. Talk to your doctor. Is that right, Joe?
That's correct. Exactly.
Well, very good. So you may have seen Joe several months ago. We did an interview with him, and there's so much going on in the news right now. I thought I would have Joe come and talk to it because he's kind of in the trenches with patients on a day-to-day basis. So let's start, Joe. Tell us a little bit about you and what you do.
Sure. Thanks for having me back. Looking forward to the discussion and always advocating for care for patients dealing with obesity and happy to help provide more clarity, hopefully. But my name is Joe Zucchi. I'm a physician assistant. I'm the clinical supervisor of transition medical weight loss in Salem, New Hampshire. I've been passionate about obesity medicine for many years now. I actually just came back from the Obesity Medicine Association conference about a week and a half ago. So it's always great to touch base with the providers in the field, and it's a growing field, and everyone's very passionate and advocating for care. And there's a lot of exciting medications in the pipeline. And of course, it's about the comprehensive approach. And in our practice, we try to really focus on all facets of health, from nutrition to lifestyle intervention to activity. But medication's powerful, and it really helps to affect the biology that can be so challenging for patients. So hopefully we can help to clarify things for patients that are confused or worried about loss of coverage or the changing landscape that seems to be happening quite quickly.
Well, and so to speak to that, and this is why I had reached out to Joe to say if he wanted to chat again there's a lot of people out there afraid of losing access to their medication, and there's a lot of reasons, and we'll kind of go into it, but certainly compounding potentially going away, various insurance and PBM changes. There's a lot of things going on, and you're scared. So Joe's somebody who's in the trenches, as I said, every day, kind of helping patients out. So we'll talk through a bunch of that stuff. We always like to kind of start out, though, with a conversation around obesity and kind of level set, because we have a lot of new people coming to the channel every day. People are saying, what is a GLP-1? So help us out, kind of that higher level question. Start us at the very beginning, Joe.
Sure. Yeah, so I think as new as these medications sound, GLP-1s and this class of incretins is what we call them, has been around for 20 years now. The first one came out in 2005. It was called Byetta. And we've evolved over the years. So they used to be daily injections, and now they're weekly injections. And there's oral options coming soon as well. So this class of medications is kind of mimicking a hormone in our body called GLP-1 that typically we get released after eating a meal. And that's part of the signaling cascade to our brain to tell us we're full, we're satisfied, helps with regulating appetite. It also plays benefits on blood sugar. That's why these medications are also approved for diabetes. And they work in several ways. A lot of patients will say they have less cravings, less food noise. They're able to feel fuller faster. Part of that's because the medication not only affects the appetite region in the brain and the hypothalamus, but it also slows down how fast food leaves your stomach. So it kind of slows digestive emptying, and that helps with fullness as well. And it directly improves insulin sensitivity and blood sugar balance. And there's even some, studies ongoing about other things that they benefit from, the indications now for sleep apnea and cardiovascular risk reduction. And there's new data showing great benefits on fatty liver disease. And we're seeing it benefit inflammation and just general health. When we know that when people are losing weight, that's going to benefit their metabolic parameters across the board. And so it's exciting for me as a provider to help patients to, certainly look at this full picture, but also give them a tool that can assist in that. And I think for a lot of people, they unfortunately feel like, it's like a cop-out to use a medication, but you should not think of that as that's not the case at all. This is just the same as somebody who has high blood pressure and needs a little bit of help with a hypertensive medication, or if somebody is on a statin for their cholesterol. We don't chastise those patients for using a medication to help. If anything, they're being proactive. So we always want to think of this as a tool, but it's a powerful tool. And definitely we've had, hundreds of patients who have lost a significant amount of weight, and that translated into health improvements too. And so as amazing as the GLP-1 class is, there's revisions and improvements. And as we'll talk about, tirzepatide is not just a GLP-1, it also targets GIP, which is a second incretin hormone. And there's medications in the pipelines that will target 3 different receptors. And there are other medications that are older that we'll talk about too, for perhaps that are a bit more affordable. So a lot of options out there, but hopefully that kind of gives you a general sense of things.
So talk to us about the changing landscape of access and affordability right now.
Sure. It's changing all the time. So when this gets published, it'll probably be already something different, right? But basically, so we know that just at least in the United States, and especially in my state of New Hampshire, coverage is not, obesity medications are not a standard of benefit. Medicare does not cover anti-obesity medications. And hopefully that changes in the future. But for right now, about half of patients have coverage and half don't. And that varies dramatically. It depends on your employer and the plan that they are opted into. And as we'll talk about, your pharmacy benefit manager, because they can sometimes dictate your formulary, which is basically what medications are options that are available to you. And for some plans, these are a covered option. For some plans, they're unfortunately just considered a plan exclusion. They have opted out of covering them, often for the sake of cost. And that allows patients, unfortunately, to not have the option to use that medication. And so for patients with coverage, most of these medications will require prior authorization. And that just means we submit paperwork to your insurance to showcase why you are a good candidate for the medication. Usually we have to submit documentation, your BMI, body composition, perhaps what have you tried in the past, either medications or lifestyle intervention.
It's a showcase.
Exactly, yes, showcasing everything.
Of all the things. I like
all
that.
The details. and even that process varies by plan. I do prior auths myself for my own patients, and there are some that are, 5 quick questions, and some of them they want me to submit the patient's firstborn child and their social security number.
Yeah.
I'm joking, but they really do have complex questions for some cases. And sometimes they have step therapy. The patient needs to have tried and failed XYZ before they'll eventually cover this. So it's tricky. And as providers, it's hard because we don't have some perfect database that tells us what you have coverage for. And so oftentimes the best option is patients can call their insurance and say, what do I have coverage for? And list some names of options such as, Zepbound or Wegovy. But there's also, other ways. Sometimes providers can do a coverage check through some tools. There's a website, Wegovy has a coverage checker on their website. So they're not perfect, but they help. But of course, with this landscape constantly changing, it's getting more tricky to keep up with for sure.
Yeah.
So do you think there's an advantage for patients to working with an obesity specialist versus a GP or something?
Definitely.
In getting those PAs approved?
Yeah, I think, primary care is varies so much. There are some primary care providers who are very well versed in this field and they feel comfortable prescribing it. They understand the dose titration. They understand the process of prior authorizations. But there are also some that perhaps, unfortunately, some still are biased against treating obesity as a disease. Some of them are not comfortable or they don't have the time, unfortunately, to do the prior authorizations. I had a patient I just saw last week. They've been waiting 1 month for their primary care to get the approval, the prior auth approval for their Zepbound medication. I did it for them that day and got it approved within 24 hours. So sometimes, it takes a little bit of effort, but you have to have the right tools in place. And, usually an obesity medicine provider will be more well-versed and understand the process because we're used to this day in and day out.
Well, and have the staff too, to be able to do the prior authorizations.
Right.
I mean, I know when I started, I went back 3 months later to do my first checkup. And my doctor, he was like, I had to hire somebody just to do the PAs.
Yep. We're seeing that more and more. Exactly. It's a lot to keep up with. And not only do you need a prior authorization to start the medication, but you also will typically need one to continue the medication. So after a patient gets approval, we usually see it's approved for like 6 months, for example. After 6 months, we need to submit documentation the patient is doing well on therapy. Have they usually lost and maintained at least 5% of their weight loss? And then they'll usually reapprove it for typically another year. So it's not like, if you see an expiration date on your prior auth, don't think that's the end of it all. You can get prior auth reapprovals, but it just requires continued care to make sure those are staying in place. And to know about prior auths, sorry, I was just going to mention if a patient has coverage for Ozempic or Mounjaro, they often unfortunately see that and think, oh, great, I'll use that. But the prior authorization for those medications is based on diabetes. And so they will need an A1C higher than 6.5, or typically a fasting glucose higher than 126 to get that medication approved. And so whereas Zepbound and Wegovy, those are approved for weight management, and those would require usually a BMI over 30 or a BMI of 27 plus a comorbidity. And so that just kind of clarifies those different scenarios.
Do type 2 diabetics who are on Mounjaro or Ozempic, once they get their A1C down, can they no longer be approved, and then they have to move to Zepbound and Wegovy, and then they don't have a high enough BMI? And I bet that's a whole nother set of issues.
Great question. Yeah, that's a really good point. So typically no. And the reason is when we're doing the prior auths, and if done properly, we should always be documenting the initial either A1C or BMI, because this is a chronic disease. And that's a good point, because sometimes providers unfortunately will say, oh, the patient's BMI now is 24, so therefore it's going to get denied. You need to write specifically the initial BMI prior to therapy was, 32. And now with therapy, it may be here, but the initial was here. So that patient still technically should at least qualify because of that. And same with diabetes. If their A1C was 7, now it's 5.5, it still should qualify because of that initial number. But good point.
Yeah, something that for patients to keep in mind to remind their doctors maybe that aren't obesity medicine specialists. Yeah.
Well, but you bring up the point about chronic disease, and we talk about it all the time. But if you're new, talk to me about obesity as a disease and how that thought process is different.
Yeah, very passionate about that. I think so many patients I see come in and they feel like it's their fault. It's, I just need more willpower, or if only, I just got to get these things in a line. And I don't want to downplay lifestyle. That's a huge part, but we also don't sometimes give enough credit to how much biology influences our appetite, and our environment is so challenging. So obesity is a chronic, multifaceted, neurobehavioral, often relapsing disease. And part of that's because the body has a compensatory response. It sees weight loss as a survival threat. It does not like losing weight. And so it wants to go back to its old higher weight as like a cushier set point to basically stay at. And so when we try to lose weight through lifestyle intervention, our body typically will increase hunger. It'll increase cravings. It'll actually decrease fullness. And this is hormonal aspects at play here. And actually our resting metabolism, unfortunately, also goes down, because now that we weigh less, we burn less. And so all of those things, unfortunately, cause a lot of patients to lose weight to gain it back. Most people have lost weight before. That's very, successful for a lot of people, but sustaining that is the hardest part. And that's why this is a disease, because there's a biology component to this, both hormonally and neurobiology as well. And plus you put us in this very challenging environment, right? We have each our own genetics. We have our own food choices. Our access to foods vary. Our often lifestyle is very sedentary. These things make it hard as well. And then you combine all of that with the challenges we have trying to just get access to medication. And that's why it's so frustrating for patients to be battling this. But when we can get someone, the right tools, I always tell patients, these medications aren't in place of good habits, they're alongside them. And often they enable those good habits, because now you're able to stick to your routine more consistently and feel like you're finally seeing progress. And that's really empowering.
I've never heard anyone describe it as a relapsing disease. Obesity is a disease and it relapses. Like that's really interesting to think about, because a lot of times we think about, we go on a diet, we lose weight and everything's great, right? But then we rebound and we gain the weight back, or we relapse and rinse and repeat. So that's an interesting way to phrase that. I like that.
And I think with the medications, a very common question people ask is, well, once I lose my weight, can I stop the medication, right? And again, the chronic nature of obesity here, unfortunately, that's probably not the case for everybody. There may be 10, 15% of patients that may be able to be okay. I don't want to make people feel like it's impossible, but for a lot of patients, it is a chronic therapy because of that exact aspect. But think of this as no different than any other disease, right? Hypertensive, diabetes, again, high cholesterol. When a provider puts someone on, a blood pressure medication, and now their blood pressure is 120/80, we don't say, okay, all set, let's stop that medication, right? No, we would say, let's continue that therapy because it's helping you to maintain that. And the same goes for that. In fact, in Zepbound's label now, the indication is not just to lose weight, but to maintain weight. And that's the key. We saw that in one of the trials, after 36 weeks, they had patients either stay on the medication or stop the medication. They lost 20% of their body weight by week 36. If they stay on the medication for another year, they lose another 5% and end up losing around almost 26%. If they stop it at week 36, they gain back half their weight within the coming year. And so that's, it's a big difference there. And again, everyone's different, but that just gives us an idea of how much of it can impact it can make.
Well, and it points to why people are so scared right now.
Of course.
Right.
It's they
don't
finally,
take away my medicine. What am I going to
Right.
do? I'm going to gain all my weight back. Yeah.
Right.
and they finally found something that works, right?
Exactly.
So, and you don't write compounding prescriptions, do you? I don't think.
We've always just done the FDA-approved medications here. I advocate very hard to get coverage for patients, and I will be doing appeals and prior auths, as hard as possible. I think, part of it was certainly I think there are instances where there may have been, certainly good versions, but there were also some versions that were contaminated, or I was just concerned about someone's safety. And often the places they were getting them were not necessarily advising those patients properly. So there was that concern. And the other part, honestly, was that we knew compounds were always just a temporary filling of a void during a shortage, because that's the loophole of basically allowing compounds is when a medication is on an FDA shortage list. And eventually, assuming the medications were out of shortage, we knew this was unfortunately going to come to an end. So I hate to create false hope for somebody, and I felt safer with the FDA approved medication, but I feel for those who have benefited and are now looking for what are their plan B. And I hope we can help them and hope we can advocate for coverage for everybody, because it should be covered for all and they wouldn't have to pay out of pocket.
Yeah.
Well, so talk to me then about a patient who comes in who has done well with compounding,
Sure.
and says, "I'm in trouble. Help me out. What do I do next?"
Of course. So everyone's different. So we definitely want to have that discussion and figure out what we have for options. And so first, if somebody, I like to go through the whole landscape of options, because as amazing as the GLP-1 class is, we have older medications too. And so for some patients, let's say they don't have coverage for GLP-1s, and we'll talk about how to check coverage, but assuming they don't have coverage, and cost is a factor here. Yep. So one of the most affordable anti-obesity medications that came out in 1959 is called phentermine. It's not perfect, but it's a stimulant. Patients take a half a tablet at breakfast and a half at lunch in our scenarios, or sometimes they take a full tablet at breakfast, and it works well. It reduces appetite, reduces hunger. It does benefit people's energy levels a little bit. In terms of side effects, it can sometimes cause dry mouth or insomnia, or if somebody's sensitive to stimulants, they could be a little jittery, but we can adjust the dose. That medication, is not a bad medication. It averages 5 to 10% weight loss, depending upon the dose. And the good thing is it costs around $15 out of pocket. So that medication is generic. Exactly. Yeah. You use one of those good old GoodRx savings cards at your pharmacy, and it makes it pretty cheap. There's a few different savings cards out there.
I tried it before GLP-1, and boy, I got the house clean in no time.
Exactly, right?
Doing all the things.
Ready to rock.
It made me very jittery. And my doctor only let me stay on it for 3 months, and then she said I had to go off. And I know there's some different views on that, maybe.
Yeah, that's a good point. So that's because that medication was approved in 1959. And at the time, obesity wasn't a disease, right? We didn't think of it as one. And we thought of it as a temporary diet. And so they didn't think of this long-term. There were not really great long-term studies. But now there are a lot of providers that do feel comfortable using it longer term. There have been some kind of data showing good safety outcomes overall. And another medication we'll talk about, Qsymia, is approved for chronic use, and it has phentermine in it. And so that is reassuring for a lot of people too. But I don't think it's it's not a panacea by any means, but it's a decent medication, and it is a commonly used option for those where cost is prohibitive.
Interesting.
There were other medications that have come out. So you may have seen over-the-counter Ally. It's actually called Orlistat. That used to be a prescription. Xenical. It's a lipase inhibitor. So that medication actually blocks the breakdown of fat that you eat. And so instead of breaking it down, you basically excrete it out. Problem is you have GI side effects there. Exactly. Exactly. And weight loss wasn't even that exciting. It was like 3 to 5%.
Yeah.
So
we talked to one doctor who prescribed that if people were constipated on a GLP-1 to kind of.
It can stack pretty nicely in those scenarios. Yep. So can be used in some scenarios.
Yeah.
Then we have other medications that have come out since then. So when we think about the pipeline of medications over the years, then nothing really came out for a while. But then the next one that kind of got a lot of attention was Qsymia. And so Qsymia came out, and it combined phentermine, which we just talked about, with topiramate, which is a migraine medication. It's also a seizure medication. And together they work synergistically. The phentermine component kind of upregulates adrenaline and some hormones that have appetite benefits, norepinephrine and such. And then topiramate works kind of in a different pathway in the brain to also reduce hunger and cravings as well. And so Qsymia is a branded medication. It's a time-release medication, and there's a kind of a titration up in dosage. That medication, honestly, they're marketing as the most effective non-injectable medication, and that's technically true. We see about 10 to 12 maybe percent weight loss on average on that medication. And it's good. So that medication, again, coverage varies. It's like GLP-1s. Some plans cover it, some plans don't. For those that don't cover it, Qsymia is around $100 a month out of pocket. So it's expensive, but sometimes feasible.
But cheap compared to $1,000.
Exactly. So not a bad option to consider, assuming you're the right candidate for it. Topiramate has some side effects. It's not perfect again, but it is an oral option that's out there. Then another medication that came out was Contrave. Contrave, a similar scenario here. We're combining old medications together. Contrave combines bupropion, which is Wellbutrin, with naltrexone, which is an opioid antagonist. And so you have, kind of an antidepressant or an anti-anxiety medication mixed with that. And together, they have also been shown to really help with cravings. For people who have cravings and more emotional eating, that medication is often a good tool. We don't need a lot here. Weight loss tends to be more 5 to 10%. It's not as powerful, but in the right patient, it can be a good tool. And so that also is around $100 a month for those without coverage. And so that kind of covers everything prior to injectables. And then if we move along the timeline, the first injectable approved for obesity was Saxenda. That was back in 2015. And Saxenda is the same ingredient as Victoza. So they are both, just like Victoza is approved for diabetes, Saxenda is approved for obesity. And that's a daily injection. Weight loss was more along the lines of like 5 to 10%, so a bit lower. And daily injection is not too fun for most people.
I didn't like it. Yeah.
You tried that? Yeah, exactly.
I tried that. I couldn't really get anything going there. And the daily injections I did not care for.
Exactly. Yeah. So that's kind of fallen out of favor for the most part. But it led the pathway to its kind of younger brother, so to speak, which was Ozempic and Wegovy. And that's semaglutide, or people call it semaglutide, semaglutide, however you'd like. But basically, that medication, semaglutide, is made a lot of attention because that is once a week injection. Efficacy was higher. We see like 15% weight loss with Wegovy, which is exciting. And patients tend to have better blood sugar benefits too. So Ozempic is very effective and even has cardiovascular benefits too. And Wegovy is not only approved for obesity, but it also has been approved to reduce the risk of heart attack and stroke in patients with obesity. So there's a cardiovascular risk reduction there. So that was excellent. And then we get even more exciting because then Zepbound came out. And again, first it came out as Mounjaro. And then Mounjaro became approved for obesity and they named it Zepbound. Same exact medication. And so, certainly the most effective medication when you look at clinical trials, and most patients would agree. Certainly Wegovy is excellent, so I don't want to downplay it. It's a great tool. But when you compare them head to head, there was a trial that looked at both medications head to head called SURMOUNT-5. They compared patients on Zepbound at the 10 or 15 dose, and then patients on Wegovy at the 1.7 or 2.4 dose, looked at them over 72 weeks. They titrated up the maximum tolerated dose. And the weight loss on Zepbound was about 21%. And the weight loss on Wegovy was about 13.5%, 13.7%.
That's a big,
so it was 47% more weight loss on Zepbound. And again, we have patients who have lost over 100 pounds on both. So it's not to say, one's not the best. But when you compare them, most patients do find Zepbound a bit more efficacious. And that's because it's not just targeting GLP-1, but it's also targeting GIP, which is that secondary incretin hormone. And it seems to help patients really work well to further reduce appetite and cravings, and also possibly tolerate it better because people tend to have less nausea. And that may be due to the GIP component causing an anti-nausea effect, which is exciting. So
how do you know as a physician whether to prescribe Wegovy versus Zepbound?
Good question.
I'm just starting. How do I know which one to go with?
Definitely. Both are great options. I don't want to downplay either. I think either can be fantastic for most people. And often now we're probably looking at someone's insurance to figure out which one's going to be covered and which one's not. If I have both covered, it's hard to argue against tirzepatide and Zepbound because it does work so well. And Zepbound is also approved for sleep apnea, so obstructive sleep apnea indication. And so we know those benefits are powerful. Technically, if somebody has a risk of cardiovascular disease or previous heart attack or stroke, then Wegovy does have some better data there. That trial is still ongoing for Zepbound, so we'll find that when it comes out. But if you want to go by the data available right now, we do have that cardiovascular benefit with semaglutide.
Interesting.
But I think both are excellent. In my practice, I have had many patients who have tried both. Most prefer Zepbound in terms of efficacy and tolerability, but some do very well on either or. So both
for the patients on Wegovy, for the patients on Zepbound who just lost insurance coverage and have to move to Wegovy, how do they move over? Like, what does that look like?
Well, but back it up. Let's tell that CVS story first and then answer that question.
That's what I was getting to.
That'll be an important topic for sure. Yeah. So it's funny. It's kind of it's ironic that at the obesity conference, CVS Caremark's chief medical officer was on the stage at one of the discussions talking about advocacy and patient care and improving access to care. And then 2 days later, they pull coverage for the most effective anti-obesity agent on the market. So it's frustrating. So
he pulled the rug out from under him, I guess.
Exactly. Right. So basically, just to kind of go back a step here, when people have an insurance plan, whether it's Anthem, Aetna, Harvard Pilgrim, Tufts, any of these different plans, that is your insurance plan, but they have a PBM typically, and your PBM is your pharmacy benefits manager. They are the ones who basically control what medications can you get and what medications are they not going to cover. And PBMs are very complicating. And the United States is one of the unique countries that have PBMs, and they're this like middleman. They just add drama and pricing increases. And so these PBMs are basically dictating, costs. They're negotiating pricing between the employer and the manufacturer of the medication. And it makes it complicating. And so when PBMs are out there, each person's plan can differ. So just because you have Anthem doesn't mean somebody else with a different Blue Cross plan has the same PBM.
Right.
The three biggest PBMs on the market are CVS Caremark, Express Scripts, and Optum Rx. There are also some others out there, smaller guys, but those are the big three. And so
they're like 80% of the business.
80% of the business. It's kind of a monopoly, right?
Yeah.
And so if you have Caremark, about 70% of people have the standard Caremark formulary, which is kind of this, basic formulary that has medications that are covered and medications that are excluded. If you have a custom formulary, that means your employer kind of has its own specific plan. This new news that just came out basically last week says CVS Caremark, the standard formulary, has dropped coverage for Zepbound as an anti-obesity medication. And so very sad, very frustrating. A lot of patients have been, affected by this. It's the biggest PBM, and so it's going to impact a lot of patients. And so when we look back now at the scenarios, we're going to have to kind of go back to the drawing board and figure out who's affected. Often now patients will be getting letters in the mail. I've gotten letters in the mail from CVS saying which patients are affected. And now we have to figure out what's the best avenue forward for these patients. And we'll kind of discuss that.
Well, because there's a lot of people confused because CVS owns a lot of things. Talk about that.
Yeah. So I've seen online, people are like, oh, I'll just switch from CVS to Walgreens. I wish it was that easy. Unfortunately, this is not a pharmacy issue. This is a pharmacy benefits issue. So you may have a separate insurance card for your PBM, or the numbers may be on your card, but it's different than where you get your prescription filled. It's kind of who handles your benefits coverage. And so if CVS owns CVS Pharmacy, CVS Health, they own Aetna, they own CVS Caremark. So it's a big, big brand here. And when they make changes, it affects a lot of people. And so the way that they phrase this, I'm sure they negotiated with Novo some rebate or cost reduction on the back end. So it's hard to know because what the list price is for a medication, Wegovy's list price is around $1,300 and Zepbound's around $1,000, but nobody pays that. First, there's cheaper options for patients paying cash, and we'll talk about that. But even when insurance covers these medications, there's a lot of behind the scenes rebates going on where they're offering a stipend back because they are doing volume or whatever it may be. So it's hard to know exactly what costs are. But assumingly Caremark struck a deal here to offer Wegovy as their preferred GLP-1, and therefore they're no longer covering Zepbound, at least as of now. This may change. From what I've heard, it is not an exclusive contract. There's no stipulation saying, we're only covering this, but as of right now, they're preferring or they're opting to cover just the Wegovy as well as they still may cover Saxenda or Qsymia possibly as well. But a lot of patients are affected who had Zepbound approved.
So I've seen a lot of speculation online about, well, is there a way for your prescriber to write a continuance of care piece? And is there some sort of workaround? Do we know anything yet? Is there?
Yeah, that'll be very important to figure out. So I sent an email out to all my patients that were affected and just kind of said, here's what we know. As of right now, basically Caremark is going to change coverage starting July 1st. If you had a Zepbound prior authorization approved, it'll switch to Wegovy theoretically just automatically until the expiration date of your original Zepbound prior auth. And going forward, patients will have coverage for Wegovy, but not coverage for Zepbound. But to your point, we want to figure out if patients really did benefit from Zepbound, or they tried and failed Wegovy and they couldn't tolerate it, or they have sleep apnea, or maybe need a higher potency because Zepbound causes more weight loss at the higher dosages. Can we advocate for those patients and continue to get coverage? So if there is a way to file it, we would try to do a kind of a formulary exception request and state and advocate why this patient should stay on this medication because it's in the best interest of their health. And if there is any way to do that, I certainly plan on doing that. If a patient, has been doing fine and feels comfortable switching to Wegovy, that is a fine option. I'm glad they're still covering an anti-obesity medication. But if a patient really, needs Zepbound and prefers Zepbound, then I hope we can find coverage for them. There are the out-of-pocket options, but I'm curious to see how hard CVS is going to make it to get these exceptions approved for patients who need to stay on Zepbound.
So back to Lorraine's question about what does it look like when you switch from Zepbound to Wegovy and dosing and all that stuff.
Yeah, so there are no trials that have been officially looking at switching from one to the other, right? There's no documented data. So we're going off of our experience as providers to figure that out. And this is really important. Patients should really try to, if you're losing coverage here, you want to talk with your provider to get a game plan in action. Because the last thing we want to do is to stop medication, hope for the best, and likely experience weight regain. Or, if somebody takes time off and then restarts it, they could get nauseous if they haven't been on the medication for a while. So, as you know, these medications, you start low and you go slow and you titrate upwards. If you're off of it for more than a few weeks, there's a high risk of nausea restarting at a higher dose. So you'd want to start lower at a lower dose. So important just to monitor things and make sure people are, get the right care here. If we are switching dose, it's going to depend on your provider's discretion. In my book, if somebody's on a higher dose of Zepbound, we may switch to 1.7 Wegovy and then go up from there. If somebody's more cautious, we may start a little bit lower and go up from there. Hopefully, we can keep them on Zepbound. We've had people switch from Wegovy to Zepbound, and then we also kind of start at 5 or 7.5 and go up from there. So, we know this. Zepbound's trial showed 16% weight loss at the 5 milligram dose, which is just the second step up. Wegovy's highest dose, which is 2.4 currently, had around 15% weight loss. And so technically 7.5, 10, 12.5, and 15 milligram dosages of Zepbound have no equal on the Wegovy front. Those are, higher weight loss, and there should be no equivalent, or there is currently no equivalent. Now there is a Wegovy 7.2 milligram medication in trials, which would be a new dose that may get approved relatively soon. That would potentially have more weight loss at a more potent dose. So more to come on that.
I would think the biggest concern, just me as a patient that has just talked to people around the town, if I had to go from Zepbound to Wegovy, I would really be afraid of the nausea that I've heard about. I'd almost want to start not from the beginning, but even a step down than a comparable dose, just because I've heard so many people say they get nauseous on Wegovy.
I agree. I think always better to be conservative than aggressive. And if we start low, we can always go up from there, right? So the last thing you want to do is start somebody too high, have nausea, and then they want to discontinue it altogether. So start more conservative, especially somebody who has a previous, nausea with other medications or with Zepbound. And you have no harm in starting a little bit gentler there and then titrate up. So I agree on that for sure. Yeah. Other things that help, if a patient needs it, Zofran is a medication your provider can prescribe to take as needed for nausea. I don't want you to live off of it, but it can be good when you need it in a pinch. Works very well. There is also, ginger can be helpful. Usually eating smaller portions can help, spacing out meals. When people eat higher fat foods, creamier dishes, heavier meals, they tend to feel more nauseous. So trying to just, simplify things for a little bit and make sure you're getting plenty of water, you're getting your protein in each day. All these things are going to also help just overall health. But try to make sure the last thing we want somebody to do is get dehydrated or be losing fluids if they had any vomiting happening. So hopefully these transitions will be smooth.
What's your thought on Rybelsus? And I know they've got some higher doses that are in the works as well.
Yeah, so that'll be interesting. So Rybelsus is the only current oral medication that's approved for diabetes. That's a GLP-1. Rybelsus is semaglutide. It's the same thing as Wegovy and Ozempic, but it's oral. Now, I want to just point out here, I've seen on the online some places selling tablets and gummies and under-the-tongue drops of GLP-1s. Those are not going to get absorbed. Unfortunately, these molecules are peptides. Peptides are long chains of amino acids. If you eat it and you absorb it, your stomach is going to break it down and digest it just like a piece of chicken. And unfortunately, that's going to degrade the structure of that protein, and it's not going to have any effect. And so as much as it would be nice if these were just simple as taking them orally, there's a reason why they're injectables. We're bypassing digestion by doing it as an injection. Rybelsus is unique. It is a very complicating snack molecule that basically allows it to get absorbed through the gastric wall. You have to take it half an hour before eating in the morning on an empty stomach. It's very specific protocol. And even with all that in place, the absorption is less than 1%. It's a very poor absorbed medication. So the dosages of Rybelsus to equate to the same amount of weight loss of Wegovy need to be much higher because of that. And so the dosages approved now are in the teens for diabetes. To get decent weight loss, we're looking at the trials are showing 25 milligrams or 50 milligrams. And those hopefully will show weight loss a little bit closer to perhaps Wegovy. But I still worry about GI side effects. And think of it this way, 25 milligrams would be taken every day or 50 milligrams every day. Wegovy's highest dose is 2.4 once a week. Shows you how much of a difference in the absorption rate.
Yeah. I mean, does that do anything to your stomach when it's breaking down that amount of medicine?
I think some of it gets lost and just degraded, and it just gets, broken down into peptides or amino acids, which is fine. And then the little part that does get absorbed is going to be the active ingredient that's going to do its job. But I think it's typically not as well tolerated as the injectables. So it will be exciting, and certainly we'll see what the data shows on that. But what will be exciting is next year, orforglipron should be coming out from Lilly, which is the first GLP-1 that's a non-peptide. It's a small molecule that actually can be taken orally and does not have the same issues that semaglutide does. And so that medication doesn't require taking it before meals or on an empty stomach. That'll be easier. And hopefully, we'll see where costs are and efficacy, but a lot of stuff in the pipelines.
I hope it costs less. I hope it's more affordable.
Think of it this way, right? Zepbound and Mounjaro, those medications are kept cold. They're put into pens. They're shipped cold. They're kept at the pharmacy cold. It's a lot of work to manufacture these pens. And part of the shortage initially. So pills are a lot easier to manufacture. They don't need to be kept cold, and they can be mass produced. So I would hope that leads to better pricing.
Yeah.
Well, and Lilly's already said they have millions invested in pills sitting there, even though they're not even approved yet.
Yeah, there you go. It shows you
they
right there.
don't want to go into shortage on that. That's for sure, right?
Exactly.
They don't want to lose out on another medication going into shortage.
So back to the compound conversation, because obviously there's a lot of people just terrified, right? They've lost their weight or they've started losing their weight, and they're going to have to come to probably a new provider or certainly speak to somebody else to figure out what the next steps are. So when I walk into your practice, what do I need to bring with me? What are the steps that I can do to help you make the best decision with me?
Definitely. I think, any medical records, any lab work that you had done recently, if there's any chance of getting these medications approved for diabetes, we would certainly take that attempt. And if there is previous high blood sugar, that could be an option. Certainly based on BMI and such, we would try to get coverage for the branded medications whenever possible. But understanding each person's different, how they did on the other medications, what medications were they on? If it was a compound, what dose were they on? Sometimes it's tricky to know because they're dosed differently. But So I would say when you're bringing in, coming into a visit, just helping the provider understand what you've tried in the past, perhaps generic medications, perhaps compound medications, perhaps random medications. What doses were you on? Any lab work that you have would be helpful. Even helping us to understand your weight history. Where would you started at? Where are you at currently? Are we trending in the right direction? Are we having struggles? What other, previous diet attempts have you made? Lifestyle interventions, exercise. Tell us about your comorbidities. Do you have hypertension? Do you have sleep apnea? Do you have, history of heart disease? What's your family history? All these things are going to help us to really paint the full picture so we can understand the best treatment plan and coordinate care. And, this is hopefully not just a one-time visit. This is a continuation of care with you and your provider to follow up things, whether we're starting a medication or we're trying, lifestyle intervention, or hopefully both. We want to keep close tabs on things, because if patients struggle, we can fix things and kind of correct the tide here versus letting someone have to wait 6 months or a year to come back in and start over again. So It's very important to keep connections with patients. And I'll discuss in a little bit what costs are for people that are looking to stay on tirzepatide or semaglutide, if that's an interest for them.
No, absolutely. So how do I phrase this? There's lots of medical professionals out there decrying the evils of compounding, and we don't need to argue that right now. But as a patient, if I've been on compounding, it's been worked for me, and I now have to find a medical professional that can help me move forward. I'm a little scared, honestly.
Sure.
That you're going to come in and say, well, why were you doing that? And honestly, just grief.
Yeah, no, I understand that. It's a good point.
Well, and I've gone into my doctor with this question, and and I understand the doctor's point of view. You don't know what compounding farms, you don't know what they're doing. Like you can't know. So, but how should I, I don't want the doctor to be like mad. You know what I mean? Like,
I understand completely. Yeah, I think, and hopefully if people are getting the right care, their provider understands the struggle this person has gone through and understands the reason they went down that route was because they really were looking to, advocate for their health, and they had to put this into their own hands and take action. And so I think, I never want to chastise somebody for using compounds, or if they even did some crazy fad diet, they tried something that they hoped was going to help them. And I'm always, going to, applaud them for taking effort. So I don't want people to ever feel like they should be ashamed. It is sad if a provider does, chastise them for that. I think we need to understand people are doing this for their health and they have their best interest in mind, and whether or not they did it the right way or the wrong way, we're here to help them continue forward on the right path. So yeah, it should very much be about a compassion. I think, weight management is a very sensitive topic. Some patients are afraid to even go in for a visit because their provider is just going to yell at them for the 5th year in a row that their BMI is over 30 and tell them to just eat less and move more, right? And that's not the answer. If that was the case, we wouldn't be in this scenario to start with. So I hope providers will be, kind and welcoming to patients from whatever struggles they've gone through, and help them to just understand what they have for options. And even if somebody struggles with their weight and gains back the weight, they shouldn't feel like they failed. This is just a roadblock in the journey. Let's get back on a routine and let's continue moving forward. I have a wall of patients' pictures who have lost, significant weight. Every single one of those people had a week or two or month or maybe longer in there where they struggled. It is not going to be always, sunshine and roses. Sometimes there's challenges in there.
Yeah.
So just continue to stay focused. If you have a provider who doesn't treat you fair, then time for a new provider, right?
Yeah.
Bingo.
Well, I really appreciate the compassion that we see from obesity certified doctors. They really seem to be a different breed than a normal practitioner. Nothing against normal practitioners, but I never had a regular practitioner who was maybe understanding or caring. They always told me to just eat less and exercise. So that's what I attempted. Sure. And then now talking to different obesity medicine specialists, it's just like, where have y'all been all my life? Like, I've got to find one of you near me so that I can have this kind of relationship with a doctor. It's very hopeful to see that there are doctors out there that are compassionate.
Yeah. When I was at the OMA conference, these providers really care. I mean, there's always somebody who may not have the best intentions, but most people really in this field are very passionate. They've seen the struggles of their patients. They've lived through their journey. They understand the biology of why this is not a willpower issue. This is a biological aspect.
Yeah.
And they really respect patients and understand the challenges, and, hopefully have some empathy for them to really help them through it. So yeah, I think, you want to have a provider you can trust and who cares for you, hopefully can, fight for you and advocate for you whenever it comes to coverage, but also is there to support you, because there's going to be challenges and there's going to be celebrations. And we want to just make sure that somebody's getting the right care, because they should never feel ashamed for getting help. They're focusing on improving their health. That's something that they should be applauded for.
You should never feel ashamed for getting care. I like that.
Exactly. Yep.
Yeah.
It's 100% true.
Well, so let's talk about cost now, because obviously, certainly accessibility is one of those things, but affordability, and whether Lilly and Nova like it or not, one of the reasons that people have been using compounding is because it can be significantly cheaper.
For sure.
So as I look forward, what are my options going to be?
Yeah. And, for good or for bad, the compounds seem to have kind of instigated the reduction in prices that Novo and Lilly have caused. So that's a good thing, right? So I am the first to say the prices should come down and hopefully will come down, so we can improve access to care and make this a standard of benefit for all insurance plans. So you don't have to be fighting over costs. But yeah, for the day we're in today, if somebody, we talked about all the other medications that are out there, they're decent. Weight loss varies, and those medications are more affordable. But we do know there's power in the GLP-1 class. And for a lot of patients, it's been a game changer. It's been a life changer. And it's hard to lump them in the same category, because for some people, this is the first thing that's truly worked for them. And so if you're one of those patients where this is something that you plan on staying on and you're trying to figure out, what do I do now? Here are options. First, by all means, try to get coverage if there is any way. If there's a way to get coverage, great. It still will depend on your plan and your employer. Advocate to your employer. Advocate to your HR department. They're the ones choosing the formulary at the end of the day. Maybe you can tell them, and they can have other patients or employees say, you know what, this should be a covered benefit. It's going to help improve the health of our entire staff over the long run. They may not see the price, the savings initially, but over the course of 10, 20 years, I hope they will. But again, advocacy is always helpful. But for today, when it comes to costs, we have two options from the big manufacturers. So for those that are looking to stay on tirzepatide, which is Zepbound, that medication is available at the local pharmacy without coverage with a savings card for about $650 if you really want the pens. Those are the auto injectors. No matter the dose, it's $650. Exactly. There you go. They're very easy to use. You don't even see the needle, so they're a nice option for patients. They tend to be very well tolerated. $650 is the cost out of pocket with a savings card from Zepbound.com. If you have coverage, also get the savings card, because it takes off $150 off your copay, and it can bring it down to as low as $25. So most of my patients that have coverage for Zepbound are paying $25 a month. Now, what Lilly did to kind of help in this whole aspect to reduce costs is they came out with something called Lilly Direct. And these are vials, so similar to what compounders are used to. And these vials are available at 2.5, 5, 7.5, and 10 milligram dosages. And they're single dose vials, so there's 4 of them you'd get in a box. And these are the cost of $349 for the 2.5 milligram dose for a month supply, or $499 for the 5, 7.5, and 10. They continue to get it for $499. The 7.5 and 10 have to be refilled at least once every 45 days. And so that's the pricing for that. Now, a couple things to note. One is this is more typical needle and syringe, so you're going to have to draw it up with a needle and syringe, but same style of injection. And then second is this is not available at your local pharmacy. This has to be submitted by your provider to Lilly Direct Self-Pay. It's a specific option that we would choose, and then Gift Health coordinates with them to ship it to the door, and you get it in a couple days. And so you're looking at, again, $349 to $499, depending upon the dose, if we're looking to stay on Zepbound.
So at the lowest dose of the 2.5, that's not that much more than most compounding people were paying, somewhere between $200 and $300. That's not terrible.
Yep.
But it goes up. So it obviously gets a little more expensive.
Yep.
Talk to me, though, about your Medicare and Medicaid patients, because I know with the savings cards, they're not eligible for those.
Yes, great point. So that's an important thing. So unfortunately, there's some old law that's written in the Medicare databases somewhere that says that they are not allowed to use manufacturer savings cards. And so that coupon that I talked about that makes it $650, or that coupon that takes off $150, those cannot be used for Medicare patients or Medicaid patients. And so that's frustrating because, of all people who deserve the discount, you'd think it'd be the Medicare patients. Yeah. But so the good news is Lilly Direct's prices apply to everybody, including Medicare and Medicaid. So Lilly Direct pricing is
cash price, right?
Straight up cash price. No coupon, no manufacturer savings card, no insurance. They don't even care what your insurance is. Yep. Yeah. So it kind of sidesteps the PBMs, it sidesteps all this, coupons, and it's just a flat price. Mm-hmm. And so that would be the option for that. But on the topic of Medicare, Medicare does cover, for most plans, a Part D plan is your pharmacy benefits plan for Medicare, often does cover Zepbound for sleep apnea with obesity. Mm-hmm. And so if you have sleep apnea, the criteria needs to be moderate to severe sleep apnea. So that means an AHI score of higher than 15 is kind of the criteria. Then it's worth having your provider try to get coverage through your Medicare plan for Zepbound, because that is an option. And same goes for Wegovy. Wegovy, not the same, but Wegovy is covered for patients with a specific indication, and that is those that had a previous either heart attack, stroke, or peripheral artery disease. If they had that and also have obesity, they also can likely get approval for Wegovy. Those are the only two instances in which Medicare will cover these medications right now, because it is not covered just for obesity, unfortunately, at this time.
How is sleep apnea diagnosed? Is it a sleep study? Does the doctor just say, yeah, you have it? And what do I have to do for that?
Good question. Yeah, so it's going to be a sleep study that would be done. They're typically done in the hospital, but they now are often done at home as well. Mm-hmm. And you're hooked up to some devices that are measuring things. Mm-hmm. But yeah, as many patients may have sleep apnea because they're snoring, or they may wake up in the middle of the night gasping for air. Yeah. And they should get a sleep study for sure. But you would need to have a documented sleep study to get this medication approved, because they're going to want to see that sleep study in the prior authorization process.
Gotcha.
So, the trial on Zepbound showed, a 50% reduction in the AHI score for patients on Zepbound. So we know that weight loss is going to improve sleep apnea for a lot of people, and so it may be an option of also getting you coverage.
Yeah.
So that's the Lilly, tirzepatide, Zepbound, Wegovy, or Zepbound, Mounjaro side. The other side, which is Novo Nordisk and all of their suite. Talk to me about the costing and availability there.
Well, they also came out with something very similar to kind of compete in this new field. So Novo Nordisk, which makes Ozempic and Wegovy, came out with something called NovoCare. And NovoCare is similar to Lilly Direct, where you're able to now get the cost of the medication for $4.99. It's available for all dosages. So for Wegovy, that's 0.25 all the way up to 2.4. And the nice thing is this is the pens. So they're not vials. These are actually single dose pens. And so $4.99 is the price. And again, this would be shipped through NovoCare Pharmacy, so they'll ship it to you. Although I do hear it looks like CVS is part of this partnership, which I'll talk about in a little bit. CVS is going to be offering it perhaps at their pharmacies as well for that price. And so, we have options basically for $4.99 or a little bit less for the lower dose of Zepbound for patients without coverage. And regardless of plan or insurance, there is at least an option to get it for those that assumed it was $1,300. It hopefully will never be that for them.
It's good to know.
So for those people out there who have been microdosing or using alternate dose because they went up by 0.5 because they had, gastrointestinal issues or any, is there any path forward? Assuming compounding goes away, doses? Or
it's a good question. There needs to be more research on that. There's not any great trials. All the medication trials were done at these, kind of top dosages, or they titrated upwards. So we don't have any hard data to go by. We can just say anecdotally, patients have done well with lower dosages. So there are scenarios where people may be, doing well on a lower dose. Technically, Lilly's vials, they claim there's no preservatives in there and they should only be used as a one-time use and not be, broken into dosages. But, I'm sure people do what they want to. But I have seen patients who have tried spacing out their dosage because of costs. And instead of doing the shot every 7 days, they may be trying to do it every 10 days, especially if they're at maintenance and they're at their goal weight and they're just using it to kind of maintain things. That's an option that's worked well for some people. Again, it's off-label. There's no trials to kind of showcase how people do on that. We know the medication has a half-life of 5 days. So that means after 5 days, half of the tirzepatide has basically been out of your system. And so, as the week goes on, by week 2, you'll likely feel more hunger because it's not as potent as it is in the beginning of the week. But for some people, it still can be a good tool. So I think more research to be done. But again, talk with your provider, because a lot of the obesity specialists have experience with maybe some of these more nuances than others.
Well, so Laraine and I are both on maintenance, right? So I've lost 104 pounds and I've been on maintenance about 8-9 weeks. And how about you?
I've lost 54 pounds and now I've been on maintenance for almost a year. And I've gone down in dose because I thought that's what you were supposed to do at the time. Now it seems like you can go either way, stay or go down. What's your thought on that, stay or go down in maintenance?
Yeah, it's a great question. Again, the trials had people titrate up to the top dose and then they stayed there and they were kind of holding their weight. But in my practice, we definitely have had patients who reached their goal and we slowly titrated them down, monitor them closely to make sure things aren't going the other direction. But there are some people who are doing very well on just 5 milligrams or sometimes 2.5 with Zepbound, for example. And that raises another point. Zepbound was approved for maintenance dosages of 5, 10, or 15 milligrams because that's what the trial was. And most insurances, honestly, except for one, often do allow me to prescribe any of the dosages indefinitely. I can, play around with it based on somebody's doing. And that means some may be on 2.5 if they want to. Problem is Wegovy only had approval for the 2.4 and eventually the 1.7 as a maintenance dose. And so that means if your provider wants you to stay on just 1 milligram semaglutide or 0.5 or 0.25, unfortunately, we'll get denied by your insurance for saying that's not a therapeutic dose. And that's frustrating because some people are at their goal weight and we don't need as much potency for them.
Yeah.
So you can sometimes file an appeal to get like 1 more month, but it's hard to get more than that.
Interesting.
So I've seen a bunch of people as they begin to look at Lilly Direct, and you go read the website, and there are people reading more stuff on the Lilly website than you'd ever imagine. And apparently somewhere in there it says that 2.5 is not to be used for maintenance.
Correct. Yeah, that's based on the trial that they didn't
which
show.
Freaks them out. And they're like, well, I won't be able to get 2.5 from Lilly Direct. They're not going to let me.
Oh, good question. Yeah, great question. Yeah, so for Lilly Direct, I can prescribe any of the dosages, and there is no one telling us what to do because your insurance is not dictating the coverage here. And so, yes, you can stay on 2.5. I have some patients that stay on it for a few months before going up. Some because the cost was lower, they just had to stay there. But yeah, if you want to go up to 5 and go back down, again, it's technically off label, but Lilly Direct does not dictate what dose. Your provider will decide the dose, but there is no stipulation that you have to be on this dose. So there is that flexibility, which is nice.
So they're basically acting as a pharmacy then, right? They're just, you write the prescription, you send it, they fill it. They don't come back and go, well, what are they doing?
Exactly. The only things that they will clarify occasionally is they want to make sure that we submitted an ICD-10 code for either obesity or overweight to prove that this is not being used for vanity. It's being used for medical purposes. And they also will sometimes need to just make sure that we're sending the prescription properly in terms of the instructions on how to do the injection. But yeah, outside of just like any pharmacist who should be just vetting the prescriptions, they are not dictating care or saying what dose they should be on, which is nice.
Yeah, I never knew what an ICD-10 code was till I went to Walgreens and they said, we can't fill this Zepbound. It doesn't have an ICD-10 code. I was like, it's for obesity.
Walgreens is the one pharmacy that really is like particular about, they want that ICD-10 code on their prescriptions oftentimes. I think it's frustrating. Crazy. I think they were trying to avoid people using it for vanity purposes. But to your point, there are people who now have a BMI maybe of 24, but we need to make sure we're putting their initial ICD-10 code for obesity because now it is an obesity in remission, so to speak. But this person may have a normal BMI, but they still deserve that medication because they're using it to maintain their body weight, which is important.
Yeah.
So as we talk a little bit more about maintenance, any of those earlier medications are they helpful in maintenance? Is there hope if I can't afford Zepbound or Wegovy?
Great question. Very exciting kind of topic on that because we know certainly these medications, again, I love Zepbound. They're both great, but we know Wegovy averages, 15% weight loss, Zepbound up to 22% weight loss. If you just clarify that, that's around 50 pounds on average weight loss for somebody who weighs 230 pounds, right? And so 50 pounds of weight loss is significant, and some may lose more than that. If somebody gets to their goal weight with these medications and they've achieved that 25% weight loss, fantastic. Does that mean they have to, pay out of pocket forever for that medication? We know that those who stay on it will probably be the best because they're getting that benefit long term. But there was a trial that came out recently that looked at what happens if patients had to titrate or had to switch to an older medication that's generic. Can that still work? And it had some pretty promising data. It wasn't, a randomized trial that was perfect, but it did show patients that switched were maintaining their progress pretty well. And so to your point, I think if somebody, had lost a lot of weight and doesn't need to lose much more, but they just want to maintain that weight, I think utilizing, ephedrine or Qsymia or perhaps, Contrave or, again, Lilly directed a low dose, that may be adequate to help them maintain that weight.
So it's not hopeless.
It's not hopeless, never hopeless. Even if you lose coverage for every medication and can't afford any of them, don't feel like that it's an automatic weight regain. I mean, yes, there's a high chance of that, but each person is different. Everyone's genetically different. Our lifestyle, our habits. For patients who have been on these medications for years, they probably changed their habits a lot. They may now be able to move more. They're exercising. They joined a gym. They feel better. They're able to walk up a flight of stairs faster. Their, relationship with food has changed. They've bought healthier options. So those habits aren't going to go away tomorrow. Yes, without the medication, it's going to be an uphill battle because hunger and cravings could be stronger, but never feel hopeless. There's always opportunities. If you want to try without medication, that's an option. But don't be afraid to, go back into your provider if you're struggling and say, I need help, because the last thing any provider or any patient would want is to regain all of that weight and have to start over. Yeah. It's better to intervene earlier on and shift the tides.
So as you look towards the future, and we're going to wrap it up, when people talk about they have to be on these medications for a lifetime, and we both believe we'll be on some variation, maybe whatever the next version is, I don't know, but
or forklift run.
I think they freak out because they think it's going to be $1,000 a month forever.
Right.
What does the future look like, do you think? You were with all those smart people at that conference. Surely
Sure.
they talked about that a little bit.
So a lot of good news. So I'd say first, there are literally like 50 to 100 medications in trial right now for obesity. There's a lot of stuff. Yes, there are many.
100.
Some are in phase 3, which will come out in the next year or two, and some of them are just getting started in phase 1 trials. But the pipeline is booming with a lot of exciting stuff. We have GLP-1s, we have oral GLP-1s, we have GIP GLP, we have the triple G, retatrutide, which is targeting GLP-1, GIP, and glucagon. Mm-hmm. We have amylin, which is exciting, is a different hormone that has appetite benefits. That is cagrilintide, which will be paired with semaglutide. We have amycretin. There's also some other medications from Zealand Pharma coming out. So a lot of stuff, oral, injectable. There's another one that's coming out that's a monthly injection. There's even gene therapy looking at maybe permanent solutions. So there's a lot of stuff in the pipelines, a lot of it which will take much more years of data, but there's also stuff coming out soon. And I would say with competition increasing, costs should come down. Zepbound came out and the price was lower than Wegovy's list price, and you hope orforglipron comes out and that price is lower. And with other medications coming out, that'll help too. Also, which is sometimes overlooked, is the U.S. government is going to be doing price negotiations with more medications this coming year. Mm-hmm. And on that list is semaglutide, both Ozempic and Wegovy. The molecule is on the list. So semaglutide, if the government forces them to cap costs at X, whether it's $300 a month or whatever, that's going to change everything. Because then now, if they're putting a max on that, maybe that now increases coverage because insurances can afford it. Maybe that makes it covered for Medicare. Who knows? But I feel like there's a bright future ahead. But in the meantime, we're going to have some kind of treacherous territory to walk through because now everyone's plan is either opting in or opting out. And unfortunately, more are opting out lately because of costs. And so I hope that the future definitely will be much better where we have this as a standard of care. And hopefully the costs will come down so more patients have access. But I will mention, this Caremark situation, it hits hard. It hits home hard because I have patients who have done so well on this medication, and to just pull the rug out from underneath them is just unfair. And really I'll just mention it, but I started a petition. It has already almost 2,000 signatures.
Awesome. Yeah.
This petition basically is to advocate to Caremark to put Zepbound back on the formulary. I think anybody can get behind that. There should be options. I think Wegovy is a great medication. I'm glad they're still covering Wegovy. I plan on using it, and I have many that do. But to remove coverage for technically the superior and most effective anti-obesity medication on the market without any great rationale is really frustrating. And in my petition, I basically kind of document, the rationale as to why this is unfair. One is the superiority. We talked about it. 47% more weight loss on Zepbound than Wegovy. even if you put that aside, we know patients tolerate Zepbound better. A lot of the patients I have may have tried and failed Wegovy because they couldn't tolerate it. And so for those patients, I hope we can advocate for why they should stay on Zepbound. But to remove that option from providers to have either tool is frustrating. I think number 3 is we have the sleep apnea benefits we talked about. So is Caremark disregarding sleep apnea? Because that's approved indication for Zepbound. And I think we're also maybe overlooking, this is not just a GLP-1. Zepbound is a dual incretin here. We're targeting 2 hormones. So we should have options for people who may benefit from that. And that's translated to often better metabolic improvements, better A1C reductions, better triglycerides. And then I think just, forcing patients that are doing well to switch for no good medical reason is just unfair. For whatever contractual agreement they came up with, we know this is going to increase paperwork for providers. It's going to increase anxiety for patients. We're going to have to figure out what dose to switch them over to, mitigate side effects if we're switching, potentially have lapses in care as we figure out this whole, issue. And at the end of the day, PBM should not be dictating care. For them to be the one deciding what medication a patient should be on is just wrong, especially when we have 2 tools that are fantastic and similar in cost. We shouldn't be picking favorites. Let the provider, let the patient decide what's the best fit. So for anyone who's affected by this, I feel for you. Let's hope that things change. Feel free to certainly sign the petition, and hopefully we can
send me the link and I'll put it in the description so people can go to it.
I mean, we would hope that big pharma and insurance companies would be more patient focused and less money grab focused, like profit. You know what I mean? Like, how
it almost seems too simple. If you make the cost a little bit lower, it increases access, right? It almost sounds too simple. So
I mean, just lower your price. 74% of America, could probably benefit from these medications. You'd open the floodgates up, right?
Yeah, I think the response from the pharmaceutical industry will be, there's a lot of cost that goes into the development of medications, which I totally understand, and the production and all of that. There's a lot of things there for sure, but the PBMs are price negotiating and jacking up costs and deciding who gets what, and it's not fair care. And I agree, costs should come down. And, Lilly Direct and NovoCare are a step around the PBMs, which is, I guess, a step in the right direction. But we still need something better than $500 a month for patients, especially if this is something they need to stay on long term. So hopefully advocacy will continue, but don't share your voices. If you're affected by this, reach out to your employer, reach out to CVS Caremark. The more letters they get, the more this petition grows, the more people realize how much this impacts them. There are people who've written stories in the comments on the petition about how much Zepbound benefited them. Hopefully they see this and realize this is not just a change on a piece of paper. This is affecting people at the end of the day in their lives.
Sounds like we should reach out to our congressman too.
It could be helpful.
Maybe they could just take. Maybe government will just take care of it.
It would be nice, right? It would be nice.
Good one, right?
Hopefully we all can, but I applaud both of you for helping to raise awareness and advocating. And I think it's great to have a voice for patients to hear so they can understand somebody who's been through the journey themselves and keeps them up to date with the latest information. Because like you said, it's a very complicated landscape and it's changing all the time.
Yes, for sure.
Well, Joe, we appreciate you joining us. And it's, like I said, there's just a lot of people out there scared right now. And unfortunately, I don't know that a lot of local practitioners are really equipped to help them. So the fact that they know that there's somebody out there that it is possible to find, and it might take a little work, but they can find somebody.
Yeah,
exactly. There's a lot of more and more providers in the field of obesity medicine. And, the Obesity Medicine Association is a great group, but there's also different organizations. ABOM is, a board of obesity medicine physicians. PAs and MPs, unfortunately, cannot be in that group. But, I'm in the PAs and obesity medicine group. And as you know, I advocate hard for patients. And a lot of the providers that I met at the OMA, everyone is very passionate and cares. And we do what's in the best interest of patients for both their health and for their journeys. And we hope that we're all continuing to move this forward as a mission together. And at the end of the day, we want people to be healthy and live life to the fullest. So that's a good goal.
So, Joe, if I want to be your patient, how can I do that?
Yeah, so I work in Salem, New Hampshire. We did launch an online version of our program. I'm currently licensed in Massachusetts and New Hampshire, Transition Medical Weight Loss. And the online program is Transition Anywhere. And so we are a cash program, but we are working on potentially moving into insurance as well. And hopefully over time, we can grow our presence even further. Our in-office program is very comprehensive. I would like to think it's the best option available because we have 600 foods in our food store. We have a dietitian, we have social worker, we have health coaches, we have a lab on site, we do body composition, we do counseling weekly. We really try to do the best we can to create holistic, comprehensive care. And of course, I prescribe medications for patients as well, and we guide them very closely. And the online program we launched is a way to do things a bit more virtually, a little more flexibly with your own foods. And so both options are available. Our website's Transition Salem, SALEM.com. But at the end of the day, I hope you find care wherever you are across the country. There's a lot of great providers, and you're welcome to touch base with any of us to hopefully help you on your journey.
That's great. Thank you, Joe.
That's a great way to wrap it up, Joe. Thank you for joining us. If you guys haven't already, please hit the like and subscribe for the Downsized. That way, every time we publish something like this, it'll alert you and you can check it out. And we will probably have Joe on again in a few months. Who knows?
Thank you. Always great to talk with you guys, and hopefully it helps everybody just stay up to speed with everything in this kind of crazy landscape. But again, thank you for the time, and thank you for all that you do.
Very good. Well, my name is Christopher Durham.
I'm Laraine Durham.
We are the Downsized. We'll see you next time.